Good evening. Welcome back to My IVF Answers and the European Fertility Society. We are back with our wonderful speaker guest tonight. So Dr. Elias Tsakos is with us. Hello, Dr. Tsakos. Lovely to have you back. And I hope you are ready to educate us a little bit and, of course, explain adenomyosis, but also endometriosis and its impact on recurrent miscarriages. And we have your presentation right here as well. How are you? How is it going today?
Oh, hello, everyone. Hi, Caroline. Hi, everyone. It's wonderful to be here with you today on a very hot day from Greece. The temperature was 40 degrees Celsius today. That's pretty hot, especially for this part of the year. And, thankfully, we have nice air conditioning and we're nice and chilled here. So I'm ready for an exciting presentation on my favorite subject, on a subject that's combining the art of medicine, fertility medicine, IVF, and the art of surgery, which is reproductive surgery. So thank you very much for the invitation.
Thank you as always. If you haven't seen some of our webinars before, I can only encourage you to have a look at all the previous webinars with Dr. Tsakos. There were many webinars we've done in the past, and it's always interesting. So I would love to see what we have today, what Dr. Tsakos have prepared today. And of course, remember that if you would like to support us, we are still looking for some volunteers. So I hope you can do it. If you wish to get some more details, of course, get in touch with me, Caroline at EuropeanFertilitySociety.com, and I would be happy to share some things that you might be helping us with. And of course, remember that this is being recorded, and if you have any questions, you will be able to ask Dr. Tsakos directly through the chat. So don't hesitate, put those questions in the chat, and Dr. Tsakos will answer them for you right after his presentation on our topic. And I believe we can go ahead with the topic. It's interesting for sure. So over to you, Dr. Tsakos, okay?
All right, thanks again.
Thank you.
So I will go straight into the main subject of my topic today, endometriosis. This is a Greek word deriving from two parts. Endo means inside. Metriosis is the inside of the uterus. So it's a descriptive word, descriptive terminology, referring to the presence of tissue that looks like the lining of the uterus in areas which are outside the lining of the uterus. Now, I've always been puzzled by this condition, which is a fascinating condition, but also very impactful on women's lives and on the fertility potential and also the outcome of the fertility interventions we perform. So endometriosis is a perfect bridge between fertility surgery and fertility medicine. And being one of the older trainees, when in the 90s we used to train in both fertility medicine and surgery, which is not the case anymore, sadly, in my opinion. I will try and give you my perspective and my point of view with regards to the diagnosis and the management and also the impact of this disease on fertility. So this is the table of the contents of my talk, a brief overview of endometriosis, overview of adenomyosis. These are terms that may sound a little bit unfamiliar for the lucky ones who haven't been diagnosed with them, but they're very familiar to a great number, a great proportion of infertility patients. As high as 50% of infertility patients suffer from endometriosis or adenomyosis. And also I will discuss the impact on the fertility and miscarriage rate. Again, this is an area which has not been fully understood and has not been fully communicated, if you like, with our patients as to what is the effect of endometriosis on pregnancy and miscarriages, and of course the modern treatment options. I will try and keep it very short, 20 minutes max, so that we have the opportunity to discuss and answer questions. So, brief overview of endometriosis. What is it? So this is the lining of the uterus, as you can see with my cursor here. and this is the lining of the inside cavity of the uterus. This is called endometrium. So endometriosis is a condition in which tissue that looks like, it's not exactly identical to the endometrium, but it is endometrial-like tissue, and that's maybe located outside the endometrium, outside its normal position, normal place. And where that can be, it could be the ovaries, it could be the ligaments, it could be the tubes, it could be the uterus, the wall of the uterus, and this is when we call it adenomyosis. It could be the peritoneum, which is the cover, the internal cover of the organs of the abdomen. It could be distant areas like the diaphragm, like the lungs, and sometimes it can be as far away as the eyelids. What does it cause? It causes inflammation and fibrosis. So it's an area of inflammation and irritation, and of course, this is where the consequences derive from. How common is it? How common is endometriosis? As you can see here on the world map, it's about 17 to 19% in Europe and North America. So pretty common, so very near 20%. Even higher, even commoner in Africa. And the commonest is found in Asia. 36% of women may suffer from endometriosis. So overall, between 10 and 20% of women, so about 1 in 5 to 1 in 10 women suffer from endometriosis. That's a pretty common disease. And of course, in the recent years, in the last maybe 10 or 20 years, we have been able to understand the disease even more, and we have been able to diagnose it more accurately, which had not been the case in the past. Here you can see the graphs of the age distribution of endometriosis, and it's evident that this is a young age disease. It affects commonly women between the ages of 20 and just under 50. So it's a disease that affects women of reproductive age. And of course, this is very significant with regards to the fertility impact of the disease. What does it produce? What kind of symptoms are associated with endometriosis? A number of symptoms. So tiredness or lack of energy due to chronic inflammation, pain, abdominal, pelvic, regular, irregular, cyclical, acyclical, and so forth. Painful menstruation, bloating of the abdomen, which again could be cyclical, could be depending on the menstrual cycle, difficulty and painful in passing stools, passing bowel movements, painful urination, dysuria, painful intercourse, dyspareunia, and infertility. Sometimes there's no symptoms at all, and the first manifestation of endometriosis is difficulty in conceiving, in infertility. Other times it could be suspected with patients who present with a miscarriage or with recurrent miscarriages and so forth. And of course, even infertility is not evident sometimes that the patient suffers from endometriosis. They may not have any of those symptoms. It could be what we call a silent endometriosis, and it can only be diagnosed with very advanced imaging, ultrasound scans, MRIs, or eventually laparoscopy. These are three of my favorite images. I mean, if you were to take one slide out of 31 home as a message, I would suggest you take those three ones. And why? Because endometriosis is like an iceberg. What we normally see, either by scanning or by the symptoms or even by laparoscopy, is usually just the tip of the iceberg. And there's more extensive disease under the surface, and in particular under the surface of the peritoneal lining. So beware if you have any sort of suspicion of endometriosis, beware that a correct diagnosis of the extent of the endometriosis has to be made equal to diagnosing the extent of an iceberg, and invariably the severity of the disease is much bigger than what is evident. A second resemblance is the chameleon. So just like the chameleon that changes appearance depending on the environment and depending on the external stimulus, exactly the same happens with endometriosis. It can change appearance. It can change clinical manifestations. It could present initially with pain, and then the pain could become bloatness, and then the bloatness could be hazed with tiredness and fatigue and painful intercourse, and then the symptoms may all disappear miraculously before they come back, and so forth. So think of the chameleon. So regarding the physicians, the medics, we have to be very well aware to look out for hidden symptoms of endometriosis. And with regards to our patients, they have to be aware that the disease, this chronic and terrible disease, may change appearance models. And the third example I like to make is the time bomb. So someone may have endometriosis, they may know it or not. Diagnosis usually takes up to 8 years to be made. Unfortunately, due to the restrictions in healthcare delivery, in many countries, even the Western countries, access to a specialist doctor, gynecologist, or fertility specialist is not possible or is restricted, and therefore, bam, at some stage, 7, 8, 10 years later, the time bomb goes off and presents itself either with stage 4, severe stage endometriosis, or with a massive ovarian cyst, or with an accident within the ovarian cyst, or with severely damaged fallopian tubes, or with recurrent miscarriages of previously unknown etiology, unknown reasons. So keep those 3 images, and let's alert each other. As the physicians, let's alert our colleagues and our patients, and you, the patients and associations, alert each other for the presence of this terrible disease. So what about adenomyosis? So effectively, in a simplistic manner, I could say that adenomyosis is the endometriosis of the wall of the uterus. So endometrial-like tissue, instead of lying just within the cavity, it lies within the wall of the uterus, within the muscles. And of course, that disease grows, and that growth is causing pain, enlargement of the uterus, chronic inflammation, and of course, it may affect women between the age of 35 and 50, just like endometriosis. Adenomyosis may affect up to 10% of women with infertility, so we need to be very aware of this, and we need to be very careful when we assess our patients with imaging. And it's very commonly associated with infertility, endometriosis, fibroid, or all together. So these are cousin disease, as I like to call them. So what does it cause? What are the manifestations of adenomyosis? So could be heavy or prolonged bleeding. This may go unnoticed many times because it happens slowly, and women get used to that. So it becomes heavier slowly, and then eventually it's heavy, but it's happened slowly, so it's not clinically fully understood by the patients. Painful periods, painful intercourse, pelvic pain, enlargement, bigger uterus, and of course infertility. So similar symptoms to endometriosis, which may coincide also. So what is the impact of that disease on infertility, on fertility, and on miscarriage rate? There's been a lot of reports, a lot of data. I try to keep it simple. It's not a conference. I like to give you very clear take-home messages. So I'm just including a meta-analysis, a review of the literature, a recent one that was published in 2022 in the Journal of Gynecology, Obstetrics, and Human Reproduction. So the presence of endometriosis lowers the implantation rate by 16%. So that's a pretty significant reduction of implantation rate in IVF. It lowers the number of oocytes we retrieve when we do IVF. And why is that? Through a lot of mechanisms, and the most simple one to explain and understand is through the local inflammation on the ovaries. So locally, endometriosis destroys, damages by 50% the potential and the reserve, the ovarian reserve. So regardless of how efficiently we think we stimulate women with endometriosis, the oocyte yield in terms of numbers, I'm not talking about quality because also quality may be affected, is about 50% less. Now, this is a collateral damage that endometriosis is making via multiple pregnancy rates. So it's increased multiple pregnancy rates in IVF, and that's because our attempt, the medical stress, if you like, or the iatrogenic efforts to maximize the chance of success, knowing and being aware of lower implantation rates and the difficulty on those patients, we tend to transfer more than one embryos, 2 embryos usually, and of course that is causing multiple pregnancy rates. So we overcorrect, if you like, but this is an indirect complication also. And of course, ectopic pregnancy rates are higher, and again, the mechanism is through to damage, either direct or indirect, through inflammation of the fallopian tubes, and this damage is attracting, if you like, ectopic implantation of the fetus. And sadly, the miscarriage rate is also very much higher, about 77% higher in the endometriosis group. So you can see the detrimental effects of endometriosis on fertility. So what about adenomyosis? Similar findings: lower implantation rate, lower pregnancy rate, and higher miscarriage rate and lower live birth rate. So cousin disease, usually they're associated with each other, and together combined, they reduce significantly the chance of success of IVF. Right, so what can we do? What are the treatment options? I mean, I'm not going to go into very much detail, but of course, before treating, we need to diagnose the disease. And in order to diagnose the disease, we have to be vigilant, and our patients need to be vigilant. And I'm grateful to the European Fertility Society for educating, for giving us the opportunity to educate our patients who need to be vigilant about the chance or the possibility of suffering from endometriosis. I mean, I daily see and consult patients who've had miscarriages, who've had multiple IVF failures, who have suffered infertility for many years, who have done all sorts of gray and equivocal value tests, if you like, and they have not really tested, they have not really been checked for endometriosis, which is very likely to be there, especially in cases in which we classify them as unexplained. It's very difficult to put this terminology to real terms unless we've done very advanced imaging to exclude, in order to exclude endometriosis plus or minus laparoscopy. So diagnosis is more important than treatment, and being vigilant about endometriosis would increase our opportunity to diagnose timely and correctly the severity of endometriosis. So certainly fertility treatment is one of the options if the presenting complaint is fertility. I mean, if our patients suffer from pain or other symptoms, or if they have deep endometriosis, debilitating disease, then of course fertility has to be combined with some sort of surgical treatment in order to improve the quality of life. But with regards to fertility treatment, all the standard, this is my wonderful embryology team. So those smiling faces are producing lives and beautiful embryos every day. So IVF, ICSI, oocyte donation, and surrogacy could be the fertility option, either isolated or combined, in order to overcome the hurdles of the fertility impact of endometriosis. Medical treatment could be combined with fertility and IVF, either on its own or as a pre-treatment or in combination with IVF treatment. And that includes GnRH analogues, aromatase inhibitors, contraceptive pre-treatment with oral contraceptives, plus some anti-inflammatory and antioxidant agents. Having said that, the value, the place, and the clear indications and the effect of those medical interventions is not clearly defined yet, and it's not fully understood. So there's a lot more data that we're lacking in order to make conscious decisions for our patients and provide them the options. Now, surgical treatment. I mean, for many of us, including myself, we feel that endometriosis is a surgical disease. And why is that? Because invariably there's a nodule, there's there's a lump, there's a cyst, there are adhesions, there are damages to the tubes, there's hydrosalpinx, there could be adenomyosis, either focal or diffuse, and so forth. So surgical treatment has always been there, and in particular minimally invasive treatment. So keyhole surgery has always been there, at least in the last 30 to 40 years, both in the diagnosis and in the management of endometriosis. And this has been scientifically proven that the pregnancy rate is improved, both spontaneous and assisted pregnancy rates. And even in mild endometriosis, there's up to 10% improved implantation and pregnancy rates compared to no treatment. So there's always a place of keyhole surgery, laparoscopic or robotically assisted laparoscopic surgery in the management of endometriosis. Of course, we need to be very careful. We need to counsel our patients. We need to individualize. It's not one size fits all. We need to factor in individual circumstances, individual conditions, individual needs, individual disease, symptoms, outcomes that we wish to achieve, and all that in order to make a decision. That's why endometriosis management, thankfully, in the last more than 10 years now, in the world, at least in the Western world, is managed by a multidisciplinary team, which includes, of course, expert surgeons, experts in imaging, radiologists, other specialties like urologists, bowel surgeons, of course, psychologists, pain specialists, anesthesiologists, and I would like to see the fertility experts as well, which it's a little bit sad that at the moment they're not fully integrated into an endometriosis team. I would like to see the fertility experts joining that multidisciplinary team in order to make the best possible suggestion and provide the best possible option for patients with endometriosis. And equally, adenomyosis could be managed laparoscopically with regards to either improving the symptoms or the fertility, or both. Now, robotic surgery, the new kid on the block, new kid in Europe. In the US, it's probably an old kid now. It's been around in the US for about 20 years. In Europe, it started becoming popular in the last 5 years. I mean, it was introduced about 10 years ago, but the last 5 years have been decisively very important, very big in robotic-assisted surgery. And many centers, including our own, we have incorporated robotic surgery into the management of endometriosis. And again, it seems that there's no center of excellence in the world that doesn't provide robotic surgery together with of course, conventional laparoscopy in the management of endometriosis. So this is the latest available minimal invasive solution. We have all the technology advancements that help us have better control, safer excision, and less complications, pain and bleeding, better visualization, and so forth. So this is a new weapon, if you like, in the war and the fight against endometriosis and its impacts on women's lives. Now, this is a recent textbook edited by two international experts, based in England last year. One of them used to be my tutor and mentor and teacher, Professor Nazar Amso, and I'm honored to have undertaken now the edition of this book for Greece and the Hellenic region, where there's no access to similar textbooks on the current topics, diagnosis and management of the book of the endometriosis. And I think this is very important because this is part of educating our colleagues and our patients alike. Our approach in Embryoclinic is a holistic approach. We approach our patients individually in order to understand the condition, to diagnose correctly the endometriosis, plus or minus adenomyosis, plus or minus fibroid disease, plus or minus other fertility factors that may have an impact on their fertility. And then in a multidisciplinary way, we approach them in order to find the best possible solution, or the combination of solutions, which sometimes involve conservative treatment, medical treatment of the endometriosis and IVF, or fertility surgery through either conventional laparoscopy, hysteroscopy, or robotic surgery, and IVF. And of course, we're very fortunate to be in touch with international experts in Europe and across the Atlantic for very difficult cases, because unfortunately there are some cases which are beyond the scope of any unit, no matter how expert we think we are. And I'm very grateful to my colleagues all over the world for the support in this drive to give our patients the best possible approach. Take-home messages, 2 more minutes. Endometriosis and adenomyosis are very common conditions, especially in infertility. Probably up to 50% of women, probably 1 in 2 women, especially the ones with unexplained infertility and unexplained miscarriages, may suffer from endometriosis. So we have to be very vigilant and give them at least a correct diagnosis in order to provide them with treatment options. Both diseases could have a significantly negative effect on fertility and quality of life. They've been associated with adverse fertility outcomes in the current miscarriages. The optimal treatment may be the combination of surgery and fertility care at the top level, tertiary level. Robotic surgery is the latest available treatment modality that offers safe and effective solutions, even for the most challenging cases. And both surgical and fertility expertise may be required for the optimal management of endometriosis in the context of fertility. So the disease is bad, but we are getting better, and we tend to understand more and more the pathophysiology of the disease, and we seem to have more and more technology tools in order to manage it safely and successfully. This is the literature I used for this presentation, so feel free to take a screenshot of that. And these are the contacts to which you can send individualized messages or questions if you like. My team and I were very happy to provide you with feedback and even a free online consultation in the context of the My IVF Answers initiative of the European Fertility Society. So please do not hesitate to send us an email with any question, and please quote that you listened into this webinar. And thank you so much for listening, and I'm ready to take questions for the next 20-25 minutes. Thank you.
Brilliant as always. Thank you so much indeed for your presentation, thorough explanation. And you are right, we are about to start our Q&A session. And as you can see, Dr. Tsakos, questions are coming in right now. Let's go with a few parts of it, okay? From AD. Can you have adenomyosis and then it can go away by itself? I was told I had adenomyosis from a scan, but then the follow-up scans said that it's clear there's no adenomyosis.
Sure. Okay. Probably no is the answer. I don't think it's possible. It's just that sometimes the diagnosis cannot be 100% accurate on the scan, and or it could be very mild disease, which can be, if you like, sometimes be confused with normal myometrial tissue, which may resemble a little bit with adenomyosis. So, if you had two opinions, one positive, one negative for adenomyosis, it's a draw. So you may need a specialized ultrasound scan, maybe 3D technology plus or minus Doppler technology, in order to be at least entirely sure that on imaging you have or you do not have adenomyosis. But in your case, I would be very hopeful. I think it was either very small disease or just a red herring, just something that was perhaps misdiagnosed, because it's unlikely. I mean, adenomyosis, similar to endometriosis, is a chronic, invariably progressive disease. So it tends to get worse. It's unlikely to get better.
Okay, thank you.
Especially in women of reproductive age, of course.
Of course. And you've mentioned this, of course, during your presentation, but if you can give us some tips, how is adenomyosis, endometriosis diagnosed?
Sorry, Caroline, I didn't hear your question.
Sorry, how is adenomyosis and endometriosis diagnosed?
Diagnosed. I mean, the first suspicion is by the symptoms. Okay, so if someone is presenting with, and the symptoms could be positive, or the absence of symptoms could be symptoms in patients with infertility. So pain, bloatness, fatigue, painful periods, painful intercourse, painful urination, and so forth. Also unexplained infertility or unexplained miscarriages. So someone with no symptoms whatsoever, who may suffer a couple of miscarriages without any evident cause for that. Now, the first step would be, of course, the history, and then we have imaging. Imaging could be the standard two-dimension standard outpatient ultrasound, but there's more advanced ultrasound technology, which involves better resolution. I mean, think of ultrasound, like a car. I mean, you may have a city car, you may have an ultrasound machine which is very straightforward and very simple, which may not be able to diagnose, even in the best of hands, mild disease. And then you have the advanced technologically machines, which can be more accurate, and in the trained hands could be more, if you like, accurate in diagnosing adenomyosis and endometriosis. And then, of course, you have the three-dimension technology, which is even more advanced. But you need also capable hands. You need the physician, the radiologist, or the gynecologist performing the scan to be perhaps experienced or specifically trained in identifying subtle disease. It's very, very common that disease could be missed and could not be easily diagnosed. If there's still doubts, usually a negative scan in the presence of symptoms still make me suspicious. Even in my hands, sometimes with very, very high resolution ultrasound scans in our department with 3D and Dopplers, if I don't find disease on a patient where I suspect disease, I move on to the diagnosis ladder. So then I would ask for an MRI scan. And the MRI scan, again, has to be of very, very high quality, and it has to be assessed by a trained radiologist. I mean, just to give you, trained in endometriosis. It's a ladder. We have to move up the ladder, and we have to keep asking ourselves, is there a chance that we're missing out endometriosis? I mean, just to give you an example, I was recently in an amazing endometriosis course organized by a world expert, Dr. Elias Tsakos, in the Prince Grace Hospital in London. And they quoted that in London, there's only maybe 3 or 4 expert endometriosis radiologists, just to give you an idea of how rare it is to have someone who's an absolute expert. So MRI scan is the next step. And if there's still doubts, then a diagnostic laparoscopy. So it could be an iceberg. It could all be under the surface, or it could be a chameleon, which is not evident. It's like camouflaged behind tissues or behind layers, and could be missed on diagnosis.
All right, perfect. Thank you so much indeed. Okay, next question, and the next one is actually similar. So, are there any preventative measures or strategies that can be taken to reduce the risk of recurrent miscarriage in women with adenomyosis or endometriosis and endometriosis?
Yes, is the answer. I mean, firstly, we have to make the diagnosis. Secondly, we have to investigate a little bit more what could be the potential cause of miscarriages. So, we cannot attribute a miscarriage on one factor only, usually. I mean, it could be other factors as well. It could be chromosomal anomalies, could be hormonal imbalances, could be anatomical issues within the uterus and all that. So it's not easy, but I mean, we can try as much as we can in order to optimize. Now, it seems that surgical management, by removing local inflammation, improves the pregnancy rates and decreases the chance of miscarriage. Now, again, this is debatable. This is a little bit disputed. The question is, who is going to perform the surgery? What do we expect from the surgery? The surgery itself is troublesome. It may be associated with complications. How far do we go with surgery? How far do we go? Do we do bowel excision? Do we do bowel shaving and all that? So it's not easy. I mean, endometriosis management, in my opinion, is perhaps more complicated than malignant, than cancer multidisciplinary management. And why is that? Because there isn't so much data in endometriosis as it is in cancer, for example. So we have to have a team of skilled, trained, expert people, and we need it ourselves as well. Sometimes we need to share our insecurities in order to give our patients the best possible option. So it's not easy, but there are some strategies. So surgery could be one of them. Down regulation could be another, in order to reduce inflammation, although the evidence is not very clear. And counseling and discussion with our patients, and sharing our thoughts, our fears, and insecurities with our patients usually helps. And on the other hand, we should not over-treat. So, I mean, it's happened to me dozens of times. I've operated on young women with endometriosis. The ovarian reserve was diminished. I only retrieved 4 follicles out of a 34-year-old or 35-year-old. And then I created 2 blastocysts, and I was too scared that they would fail following all this trouble, and I would implant both of them, and they would end up with twins, which is not, again, ideal. So it's not easy. It's not easy. I think we have to sit down together, and we have to acknowledge what we know, what we don't know, and what are the gray areas.
Okay, again, thank you so much for your question and your answer, Dr. Tsakos. Next question. So is pathology of recurrent miscarriage and recurrent implantation failure in endometriosis the same root cause?
That's $1 million question. Probably no is the answer. But I mean, the difference between recurrent miscarriage and implantation failure could be so subtle that it's very difficult to make clear connecting associations. I'm hoping, I mean, just to share with you how unsure we are, and how unsure that the scientific world is, and myself, for that matter. We're hoping to organize with the Royal College of Obstetricians and Gynecologists a conference, a 2 to 3 day conference in Thessaloniki in autumn, just in order to address this subject. So I don't think it's always the same root cause. I think there are different entities, but in either case, diagnosis and management of endometriosis prior to either spontaneous conception or assisted conception, I believe would be beneficial. both with regards to improving pregnancy rates and also to reducing miscarriage rates.
Okay, and now we will go to the follow-up question from AD. So I've done a few 3D transvaginal scans. After the first scan, there is no adenomyosis. Do you suggest I go for an MRI?
Probably yes is the answer, Adi. I mean, I presume you suffer from infertility. You may or may not have problems. And I think you would probably benefit. I mean, if you are puzzled enough to have had 3D scans, I think, certainly in my practice, I would probably suggest an MRI scan, which not only would it finalize the diagnosis on whether or not you have adenomyosis, it would also look on the possibility of having endometriosis outside the uterine cavity. So I would probably suggest that, yes.
Okay, thank you. Maya would like to also ask, are antiphospholipid antibodies, example cardiolipin antibody, more common in endometriosis?
Maya, I don't know is the answer. I have not looked into that. I have no idea.
Okay.
What we know is that in endometriosis, all the inflammation factors are higher. Whether we measure them or not, there is inflammation. And usually we know that inflammation is an associated factor of thrombosis. So that's as far as my knowledge with the connection between thrombosis and endometriosis goes. But I do not know whether antiphospholipid antibodies especially are higher or not.
Okay, thank you for that. And what is silent endometriosis? Can this be the reason for recurrent implantation failure?
Yes, silent endometriosis is the iceberg under the surface, or the chameleon that is not visible, but it's there somewhere hiding under the tree. So this is, we call it asymptomatic endometriosis in terms of noisy symptoms. And it could be, the manifestation of endometriosis could be infertility and miscarriages. So yes is the answer.
All right. Again, thank you so much for that. Okay, two parts of the question. So if AMH is 0.01 and you have endometriosis and the patient is 39, is it possible to get pregnant without donation? Like donation, I believe here, yeah.
Sorry, say it again. I'm sorry, I didn't hear
that. AMH 0.01, endometriosis 39. Is it possible to get pregnant without donation?
Yes.
Like donation?
Absolutely, Tatiana. Absolutely is the answer. Absolutely. So presumably you have periods. If the sperm is normal, then I would, you could try for natural pregnancy. I would have an assessment of the tubes, of the fallopian tubes, a good assessment either by means of a hyphosy, the histofoam salpingography, or the X-ray HSG, or even a laparoscopy. So that is pretty important, firstly, in order to see what kind of chances you have with spontaneous conception, because you're 39 years old young, 39 years young. 39 is a very good age. I wouldn't give up on your eggs. And secondly, even if you have, I would have an antral follicle count. And if you have normal periods, which means that you probably have one healthy egg every month, with or without stimulation or mild stimulation, I would go for IVF. So I would not give up on your eggs, despite the endometriosis and the low AMH.
Okay.
I mean, explanation as an option is always there. Will be there next year, in 2 years' time, in 3 years' time. Using your own eggs as an option may not be there in 3 years' time. So I would focus on your own eggs at the moment.
Okay, perfect. Thank you so much. And there's a comment from a patient for you right here. Okay.
Let me know when you're pregnant.
Exactly. Thank you so much. So let's have a look. So are the chances of conception if you have endometriosis higher directly after surgery for this, or is it not advised to try and conceive immediately after surgery if the endometriosis isn't too severe?
Okay, depends is the answer. Depends. I mean, let's take different possibilities. I mean, if you have sort of mild, minimal endometriosis and you have successful surgery, in my opinion, the best possible chance of conception, if the tubes are normal and the sperm is normal and you're of reasonable age, is within the first 6 months after surgery. That's my anecdotal experience of 30 years. So if I'm happy with the surgery, I never advise GnRH analogs after surgery, because I feel that this is the best window of achieving a pregnancy, a spontaneous pregnancy after surgery. Now, of course, if the surgery is complex, if you've had sort of severe endometriosis with extensive sort of traumatic surgery with or without bowel involvement, then yeah, I would probably give it a bit of time to heal, for the inflammation to go away, for the post-operative um, period to settle down and all that. And I would advise conception afterwards. I mean, generally, in my experience, if the tubes are normal or fairly normal, or at least one tube is normal on a youngish patient, under the age of 43, 44, with normal sperm and normal ovulation and menstruation, I would encourage spontaneous conception. And then if this doesn't happen within 6 months to a year, maybe depending on the age, then I would resort to IVF. Now, of course, another option to always keep in mind, in my opinion, either, on anyone with endometriosis, before, after surgery, whether they contemplate fertility or not, whether they're trying for a baby or not, is oocyte freezing. Oocyte freezing prior to surgery is my standard management. Firstly, because of the fear of the effect of surgery on the ovarian reserve, of the fear of perhaps losing an ovary during surgery, although unlikely, it can happen, of the fear of scarring on the ovary, of coagulating the ovary, no matter how careful we are. Surgery on ovarian endometriosis is an insult and may affect the potential, the oocyte potential. So please keep in mind oocyte freezing prior or after surgery, regardless of whether you try naturally or not. I mean, every year we have some really nice, beautiful cases of endometriosis, not very severe. I mean, it seems that I don't know where these very severe cases go to, but we don't really very often have severe cases. Mild to moderate endometriosis, done surgery, done oocyte cryopreservation, and then the patients conceive naturally. And I think that is a good scenario. However, if it doesn't happen, then we always have the eggs. They have been frozen a year or 2 years ahead of time, and they give us a very good chance of IVF success.
Brilliant. Again, thank you so much indeed. Let's have a look. A few questions left. Do you think pelvic floor physical therapy can improve symptoms or help women to get a better quality of life?
Definitely is the answer. Definitely.
Okay.
Yeah. Any intervention, any holistic approach that can improve quality of life is good for me, good for my patients. So whether it's pelvic floor exercises or acupuncture or anything, or meditation or yoga or Pilates, anything, Eleni Fotiadou, and thank you for your question. So absolutely, I mean, quality of life is a very personal feeling. So anything that can make you feel better is very welcome.
Brilliant. Again, thank you so much. So let's have a look here. And I would like to know, does it help to be put on Lupron when having adenomyosis, and for how long? If so, are there any negative side effects? What medication can help treating adenomyosis?
Yeah. I mean, to be honest, I'm not a huge fan of Lupron because because I feel that it's there to cover insecurities sometimes, either um, after surgery or before surgery or before IVF and all that. I use it. I may use it in the context of IVF, maybe a month or 2 months or 3 months maximum prior to IVF in order to control and suppress the inflammation around the uterus. But for long term, I'm not a huge fan personally. I mean, I know that many of my colleagues, they have it standard after surgery, for example. They put women on Lupron for whatever, 6 months, 8 months, a year sometimes. I think that apart from, I think that in the context of fertility is not very compatible to my mind, because, if we've done a reasonably good surgery, I think the best chance of spontaneous conception is the first 6 to 8 months afterwards. So if we eliminate that by rendering our patients menopausal, I don't think I can't see any particular benefit after that. So, and there are side effects, of course. Yeah, there are side effects similar to the premature menopause. Thankfully, they are reversible. Nevertheless, having a woman suffering from endometriosis for an average of 5 to 7 years before diagnosis, and then suffering for a couple of years before she decides what kind of surgery she will have, perhaps having had a couple of miscarriages in the meantime, and having lost maybe 10 years quality of life, and then having had surgery, complex, moderate, doesn't matter, surgery is surgery. It hurts, it's expensive, it's risky, it's stressful, and then following that, keeping them on Lupron for another 6 months to a year, it is not something that, to my practice, I consider logical.
Okay, I guess it's crystal clear here. Thank you so much for sure. Let's have a look. Okay, another question: is there an option of treating of diffuse adenomyosis? Is it possible to have robotic surgery or any other treatment? Can it lead to complications, and what is the success rate?
Sure, Anna, very, very, very good, but very impossible question to answer. I mean, depends is the answer. It depends on the size, the location, the morphology, the symptoms, the age of the patient, and what we're trying to achieve, the history, of course, and what we're trying to achieve. Totally different management, multidisciplinary team. Adenomyosis is even more weird, if you like, than endometriosis, more diverse, more tricky. I would suggest, if you send over whatever to an expert or to us, if you like, or to another expert, some images. Invariably, we like to see top quality 3-dimension ultrasound scan images, plus or minus MRI, and then decide individualized regarding your particular care. Most people, including myself, were not very happy to operate on diffuse adenomyosis. Sometimes we have to. Sometimes we do without knowing, because we think we operate on a myoma. So difficult. I can't give you a straight answer. Individualized, but by all means, if you have some images, my team and I could give you a very specific question for your case. Very specific answer. Sorry.
Understood, of course. Is there a risk of worsening endometriosis by using DHEA to manage poor ovarian response, low ovarian reserve?
Maya, there's no evidence of that, to be honest. I mean, I probably no is the answer. I mean, theoretically there could be some sort of link, but in practice, you won't be using DHEA forever. You will only be using it maybe for 6 to 8 weeks, maybe 10 weeks. And I don't think that would have any significant effect on endometriosis. At the moment, it seems that DHEA is the one and only intervention that has some sort of scientific backup in terms of improving the IVF outcome. We're hoping that the PRP, the data on the PRP of the ovaries will come out. Maybe not in the context of what we now consider as doing a PRP. But at the moment, I think DHEA is the safest, cost-effective, and the most reasonable option you can use for maybe 6 to 8 weeks prior to ovarian stimulation. And I wouldn't worry too much about its effect on endometriosis.
Okay, again, thank you so much. So if silent endometriosis cannot be seen, how can it then be diagnosed? Do you just assume it's there and downregulate before frozen embryo transfer, or what options can be
Yeah, I
explored?
would try to diagnose it with a scan or an MRI. And if I'm still in doubt, I would probably do a laparoscopy. I mean, I think it's very important. I mean, we don't do laparoscopies very easily, diagnostic laparoscopies these days. But I think for some cases, we should have that as an option. I mean, in my department, because we're trained in endoscopic surgery as well as medicine, we don't hesitate to put a scope in and have a look instead of spending time, effort, and stress with question marks. So if you have some evidence that it may be the case, just move on with maybe an MRI and the diagnostic laparoscopy. For women in the dark with regards to possible diagnosis of endometriosis, I think the risk of and the trouble of having a laparoscopy is worthwhile compared to not having one, because then A, they can have the diagnosis missed, B, they could have unnecessary other investigations which can be confusing, and C, they may waste time with no benefit whatsoever.
Right. Again, brilliant. Thank you so much. And now we will have our final question for today. So let's have a look. I'm 46. My MH is 0.7 nanograms per millimeter. After 2 IVF simulations, I might have adenomyosis as well. I'm considering donor. However, do you think I could try IVF also with my own eggs?
Sure. Hi, Bella. I mean, of course you can try. I mean, in theory, any woman who's producing an egg, either naturally or with stimulation, in theory, they could have a successful pregnancy and a healthy child. Nevertheless, the chances are extremely low. I mean, if you push me hard, I may quote you some figures. They are very low. Could be 1%, 2%, but no one can say 0%. Okay, we know for sure that the oldest published woman in the world with a successful IVF using her own eggs, who delivered a healthy child, is 46 years old. But of course, prior to her, the oldest had been 45. So, and I'm sure that she was quoted that no one in the world has made it, and she made it. So, I think you have to make a decision with your partner, if you have one, and your clinic and your doctors. The chances are extremely low, but I don't think that anyone could stop you from trying as long as you produce at least one good egg. Now, with regards to the management of adenomyosis, it depends on the severity, the location, the symptoms, and of course, the combined decision by the multidisciplinary team and yourself. I would generally downregulate. I would generally prefer frozen embryo transfer with perhaps a downregulation of 6 to 8 weeks.
Okay. Thank you so much. In the meantime, we did receive a short question I think we can answer still. If you know, would you know that what IMAP is called in UK?
I don't, but I will look it up and send you a text.
Okay, we can find out then. Okay, brilliant. Thank you so much. Adi, I will be able to, Dr. Tsakos can, of course, text me, and I will be happy to send it over to ID as well. Not a problem. And as I've mentioned, this looks like it was our final question. So thanks, everyone, for your questions, for being here with us tonight. Dr. Tsakos, it was lovely to have you. As you can see, very nice and very nice comments and thank yous are coming up your way. Tony would like to say that it was very informative. Really appreciate the information that you have given here tonight. Couldn't agree more here. So thanks a lot. Anything else you wish to add before we finish for today, Dr. Tsakos?
Well, I would like to thank everyone for listening in. We've had 33 attendees at some stage. Even now, there's 23. Thank you. It's a great honor to have an audience like yours. I learn a lot from you. I will look up the questions that I wasn't able to answer, and thank you for the stimulation and the feedback. I mean, I like to share with you that we don't know everything. We keep learning every day. Sometimes we learn from you. You are teaching us a lot of things, and first of all, you're teaching us perseverance and courage. Thank you so much. Keep at it. 80%, 90% of you will make it, no matter what you do. You may be unsuccessful once or twice, but it doesn't matter. The majority of motivated patients, they succeed at the end, and that's a promise I can give you on behalf of the scientific community. Thank you so much. It's been amazing.
Thank you so much indeed, Dr. Tsakos. And of course, remember, we will be back to actually this week on Thursday, we will be back with some more details, some more presentations. And this time we will talk about embryo and uploadity. So if this is something you would like to learn more, go ahead and register today. And of course, we will be back, as I've mentioned, with Dr. Tsakos shortly. So thank you so much, everyone. Have a good evening, Dr. Tsakos. See you soon as well. Enjoy your evening.
Good night.
Take care.
Good
Bye.
night. Bye-bye.